Hello, my name's Julie Roberts and I'm part of the midwifery team here at Bangor University. Today we're going to provide you with a sample session of one of the clinical skills sessions that we provide for the first year student midwives. We hope you enjoy it. The skill we're going to be looking at today is abdominal palpation. And we will look at the various aspects of this skill and the associated tasks that we perform when we're doing this skill. The aims of the session will be to define exactly what is abdominal palpation, what do we mean by this term, and what do we mean by the other associated tasks such as fetal heart auscultation. It would be important to know when to perform abdominal palpation and the fundal height measurement that goes with it, both providing important information about the well-being of the baby. In this, we would develop knowledge of the anatomy of the fetus as we're feeling the abdomen and feeling for the structures that we perceive are the baby within the uterus. This gives us information about the presentation, the lie, position, and the engagement of the presenting part. These are all terms that we'll look at in a little more depth shortly. And importantly, we need to find an accurate interpretation of these findings and relay this to the woman so that she can make decisions about her care in pregnancy and she's truly a partner in the care provision. So why do we do abdominal palpation? What's the aim of performing this task? Primarily, it gives us information about the growth of the baby. When we feel the abdomen, we're looking to see, are we expecting to see this size and shape of abdomen at this time, at this gestation of pregnancy? But also by providing the fundal height assessment, the fundal height measurement, this gives us an indication of the growth pattern of the baby. Is baby growing as we expect it to grow? Has baby gained weight? Is there static weight gain? Or has baby actually lost weight, it isn't gaining weight at all? And as you can imagine, this has a direct impact on fetal well-being. Because of the rising rates of stillbirth within Europe and within the UK, Gradd in 2013 undertook research that prompted the initiation of the GROW programme. The growth assessment protocol was brought in to provide individualised growth charts for each woman in her pregnancy. And as we measure the fundal height, this figure is placed on the individualised growth charts and gives us a pattern of growth for that baby, for that pregnancy. We also get lots of other information from abdominal palpation. And we look at some of these terms here that we mentioned previously. So it may give us an idea of presentation. So when we perform a pelvic palpation, we will get an idea of what is presenting into the pelvic inlet. So what part of the baby is heading down into the pelvis? What part would we see first on delivery? We would also probably gain information about the lie of the baby. So which way is baby lying within the uterus? Is baby straight up and down? Is baby slightly off to the side, oblique? Or is baby lying across the uterus, transverse? This would be very obvious to see just by visualising the abdomen, as it would be wider from side to side as it would be from the top to the bottom. We may also gain information about the position of the fetus. So where is the baby's spine in relation to maternal spine? Is baby to the right of maternal spine, the left of maternal spine? Is baby's spine directly above maternal spine? And this would give us information around how baby is likely to deliver. And also we talked about engagement. This means how far into the pelvis is the presenting part? By doing the pelvic palpation, we can get an estimation of how far into the pelvis that baby is, and therefore how soon from delivery the baby is. So we need to look at when would we perform this task of abdominal palpation. Being an autonomous practitioner, the registered midwife, you are responsible for the care you provide. And therefore, whenever you take over care, you need to have your own baseline, start from your own baseline. Therefore, you would perform an abdominal palpation. When you are happy with the findings, you would document this accurately to ensure that we have a continuous and robust handover and monitoring of care. We would perform abdominal palpation routinely after 24 weeks. Within this, we would also provide the fundal height measurement and keep an ongoing record of baby's growth pattern. Finding out where baby is lying will also give us information as to where it is best to listen when we listen for fetal heart. The best place to listen often is on the posterior aspect of the anterior shoulder, that is, behind the shoulder that is uppermost in the abdomen, or if baby is lying directly against maternal spine, we might hear it through baby's chest. It would be important to perform abdominal palpation before a vaginal examination. As indicated, the palpation gives us lots of information about how the baby is lying and exactly what is presenting into the vagina. Therefore, before we perform such an invasive procedure, such as vaginal examination, it is wise to know what we would be expecting to find. Additionally, abdominal palpation can be used throughout labour to gauge the strength, frequency and the length of contractions. By placing the hand on the fundal area, the uppermost aspect of the abdomen, we can feel that area hardening. We know a contraction is coming, and we can remain there and feel the contraction ebb away, giving us an idea of how strong and how long that contraction is, and indicating how is labour progressing. Are we doing well? One of the first things we would do as part of the process is a visual inspection, when we would look at the size and the shape of the abdomen. Is the size what we would expect at this gestation? And what shape is the abdomen? Can we see any structures that firmly look transverse or oblique? We would need to know about any trauma or injury to the abdomen or rashes, and also abdominal scars. Is there evidence of previous surgery? This could be important for the future mode of delivery. We may also see some of the common pigmentation changes in pregnancy, such as stretch marks or stria gravidarum. This is one of the most common connective tissue pigmentation changes that we see. And following delivery, although these can become quite red at times, following delivery they can become more silver, they fade to a silver colour. We may also see the linea nigra, which is the dark line of pigmentation you see in some pregnancies. This is due to hormones and is perfectly normal. So if we look at the process itself, we would definitely need informed consent. With any procedure that we carry out, we should always inform the women exactly what we're going to do, exactly what it will entail, and we would need to update her with the findings afterwards to ensure we have that informed consent. We would need to gather our equipment, which in this case would be a pinard, which is a trumpet-shaped stethoscope for listening in, or a sonic aid, which is a handheld Doppler. Mothers prefer this because they can hear the fetal heart themselves. We'd need a tape measure to perform the fundal height measurement, and of course it would help to have warm hands. It would be important to ask the woman to empty her bladder before we perform this procedure. A full bladder can be very uncomfortable for the woman, especially during the pelvic palpation when we're pressing down in that area. But also a full bladder can distend the fetal head, can push the baby back up into the uterus, and this would give us an inaccurate reading for the fundal height measurement. The woman would be in a lying position, almost semi-supine, with maybe a pillow under her shoulders and her head. It's not advisable to keep a pregnant woman in a lying position for any length of time, because this can lead to a condition we call supine hypotension, where the gravid uterus or the large uterus presses on some of the main vessels in the body, restricting blood flow to the heart, and women can become quite faint and nauseous with this. So I'm going to show you a short video now which performs the task of abdominal palpation, feeling for the baby, and a fetal heart auscultation, listening into the baby's heart. And we'll go through the 3 aspects of palpation: the fundal, the lateral and the pelvic palpation. So first we would ensure the woman is lying comfortably. We would remove the sheet, only displaying the area that needed to be palpated to preserve dignity. We would observe the abdomen to ensure there are no rashes, scars, trauma, looking for previous caesarean section, surgery marks. We would then start with the fundal palpation, feeling at the very top of the uterus, finding the fundal area, the uppermost area. And we would use this point to start our measurement, placing the tape measure there and finding then the symphysis pubis bone, the lower end of the abdomen. This would provide our measurement, and we would place that single figure on the individualised growth chart. We would then move to the lateral palpation, moving our hands down the abdomen, feeling for firm structures which would suggest the baby's spine, and softer, more giving areas which would suggest the limbs are there. And this gives us an idea of which position the baby is lying in. We would then move to the pelvic palpation, where we place our hands just above the symphysis pubis and feel for the presenting part. What part of the baby is presenting? Is it the head, cephalic presentation, or the buttocks, a breech presentation? Once we've defined position, we would listen in with a pinard. This is the trumpet-shaped stethoscope. And we would place this on the posterior aspect of the anterior shoulder. We would also palpate maternal pulse, and we would listen in for 1 minute, counting the fetal heart and ensuring a difference between maternal pulse. Once we have counted for 1 minute, we would document a single figure for the fetal heart in the notes and ensure that that remained within normal parameters. Auscultation of the fetal heart, or listening into the fetal heart, is an important element of this procedure because, again, it provides information on fetal well-being. We have used the abdominal palpation procedure to determine where is best to listen into the fetal heart, and we talked about the posterior aspect of the anterior shoulder, so that is, if the baby is lying to one side or the other, we can listen in from behind the uppermost shoulder of the baby. Or if the baby is lying directly facing uppermost the abdomen, we could listen through the chest, and this should provide us with the clearest sounds for fetal heart auscultation. It would be important to check maternal pulse. We would palpate this whilst we were listening in to the fetal heart. This is to ensure that there is a difference between the 2 heart rates and we are not mistaking one for the other, which could have direct implications on fetal well-being. Pinods are a useful adage to the midwife's repertoire of clinical skills. Very often we will use the sonic aid or the Doppler, as mothers do like to hear their own fetal hearts. But using the pinard is a valuable skill to maintain. And what is the rate of the fetal heart? Well, the fetal heart is a lot faster than ours at a resting rate. The baseline for fetal heart is 110 to 160 beats per minute. Anything outside of these parameters, we would need to act accordingly. So I hope you've enjoyed our sample session on the abdominal palpation and fetal heart auscultation. It's one of the many skills we provide in the skills labs we have in Bangor and Wrexham campus. And I know that our students do enjoy coming in to undertake the face-to-face skills sessions. They report that it helps them immensely in practice and in placement. Well, we hope that you can join us here at Bangor University, and we're looking forward to hearing from you. Thank you very much.